So we're going to launch into this. I'm so excited about this one because this webinar, because to me, it's fascinating stuff. And the amazing thing is the way this webinar came about. And that was that I was working with a smallish company, well, a medium-sized company. I think they have like 10 offices. So, well, it's kind of a big company, but so they have about 10 offices, and they're kind of, and they're spread out over a large area, or they might have less than that. Regardless, doesn't matter. They're spread out over a largish area. And they had several issues at a few offices where they were getting more audits and looked at more frequently. And also all their offices, obviously, like everybody's, were dealing with cert audits. So they sent me several different cases from several different offices, and I created a webinar for their company using their cases, their actual billing and documentation. And at the end of that webinar, I said, man, this stuff, the problems you guys are having are the problems that a lot of practices are having throughout the country. Would you mind if I just turned this into a webinar for the general public? And they were agreeable to it, thank God. So I appreciate that, company who shall not be named, that you agreed to let me use this for everybody. And I think that is really the beauty of the code program that SPS put together, because I can take these individual issues, we can work on them, we can turn it around, win some stuff on appeal, and then come back and say, here's what we did. Everybody can learn from this. And it's really a great way to, spread knowledge out and spread experience out. So I'm going to show you today the experience we had with this one company. We're going to talk about what are we looking for in documentation? What are we looking for from the doctor's documentation? And what are we looking for from the practitioner's documentation? We're going to use the local coverage determination from Medicare as guidance. And so I hope that all the practitioners out there didn't just shut down because they say, we're talking about policy. We're going to look at the LCD from the practitioner's perspective and say, look, here are the things you as a practitioner need to be aware of regarding policy from Medicare. And I will pause and say that all of these cases are Medicare cases. Not all of our webinars are on Medicare, but a lot of them are, because that's where a lot of the issues are. But so I don't want practitioners to think, oh, this is policy. This is really the stuff that you need to know as a practitioner regarding policy. You certainly don't need to know all the policy, but there are some key things that you do need to know. So that's what we're going to cover. And we're going to talk about how you can write your notes to make the reviewer's life easier. Your goal in life, if you want these claims to get paid and stay paid, is to make sure that whoever on Medicare's end is reviewing the documentation you send in can understand it and can find the information that they need to find to, make it approved or instead of denied, right? So we're going to use these three cases from this particular company, as the examples to illustrate how to write these notes, in a better way. Mr. M is the first case, and on Mr. M, they received an additional documentation request, or an ADR, after they sent in the claim to Medicare. This person's 76-year-old with peripheral vascular disease, ulcers, and a right BK amputation. So, pretty standard stuff on that one. The second case, totally fascinating, crazy stuff. I think it really illustrates some good information. This is Mrs. P, and they got just a straight up denial on this one. The denial was for no doctor's notes. This is a 66-year-old female with diabetes and a left AK amputation, and she was going from a preparatory prosthesis to a definitive socket. So it was kind of a socket change more than anything else. It was still denied for lack of doctor notes. But I want to say there were plenty of doctor's notes, right? So it wasn't that there were no doctor's notes. It was that, the doctor's notes weren't explained or used, in a way that made sense to the Medicare reviewer. And then case 3 is Mr. H. He's kind of the outlier. This is still Medicare, but he's 48 years old, diabetes, and Charcot-Marie tooth, which is an interesting combo on the right side, and then left BK. Obviously, he had CMT on both sides before he was an amputee. And then this person's also obese. We're also going to talk about the one that probably gets missed most often, and that's this part of the LCD. In the LCD, it says that coverage for feet and knees is based on the functional need for each design feature. And this particular thing, it actually states in the LCD, is supposed to be located in the clinical notes. And the clinical notes are your notes as a prosthetist. Our notes as P&O providers need to have something about the functional need for the design feature of each foot or knee or item that we put on there. So you notice it says feet and knees. So they're talking about the billable items that also need to have a K level modifier. So not you pick a K level for a patient, but not every code that you bill needs to have that K level defined on there or labeled on the billing. Feet and knees do. So what they're basically saying is if you're going to uh, bill for a foot or a knee and it has different design features or different add-on codes that go with it, then you need to explain what the functional need is for each of those features. And that's often missing in our notes, in our P&O notes. We have like these general notes that cover all this often, but not this particular part. And our goal too is to create or is to make the reviewer's life easier, right? When we write our notes. And that just makes sense. And I mean reviewer as in human reviewer. I also mean reviewer as in computer reviewer. Having said that, if you do end up at a human reviewer level, which does happen, then you want to make sure that your notes are written in a way that that reviewer, that person can really see what they need to see. And I've heard a lot of people say, oh, these, we have to dumb our notes down and write it for, a 3-year-old because these people don't know anything. Actually, most of the time, those reviewers are nurses. So they're not, Joe Blow off the street. They are, trained professionals that do have a background in healthcare. They just don't often have a background in P&O, right? So there's a little difference. So we'll talk about how you can write better for them as we go forward. And then one thing that we can do to really make the reviewer's life easier, and actually to make your life easier too as a practitioner, is to create a timeline of care. And our second case example really illustrates this point so well that I'm going to leave it for right here. And then we're going to go back and hit on it when we talk about that second case. You also want to make a habit of reviewing doctor's notes before and during prosthetic care. So again, the notes that we're going to look at, the examples we're going to look at, highlight why that would be so important, because I can feel the eye rolling right now when I say, as a practitioner, you should get doctor's notes before you see the patient and during the time that you're seeing the patient, so you're on the same page. And the eyes are rolling back and you're like, oh, like one more thing I need to do. I don't have time for all of this. How can you expect me to also review notes and I have to know policy? It's a lot. And it's a lot on an already full plate. I totally get that. But it has the potential, reviewing doctor's notes like this ahead of time has the potential to decrease the number of claims that you're appealing. And that is where all your time is really stolen from you, is dealing with the appeal process. So if you can avoid that, that much better. So again, we have examples here with different cases to illustrate this point. So I'm not going to belabor it here. And then what I just said a minute ago, use Medicare technology, help the computer understand what you're writing. And remember too that, everything that goes through Medicare is based on words, verbiage. So we're going to talk about videos and pictures and whether they're good or not, whether they're helpful or not. But the bottom line is, Medicare's systems are set up to pick up language. And so that needs to be clear when you send in your claim, right? And then you want to make the link between doctor's notes, therapist notes, and prosthetist notes. And again, our third case really illustrates that point incredibly well. So let's just jump into these cases. Again, in your handouts, if you go way to the back of the handout, you'll see case 1, 2, and 3. And as we go along, those cases, the pages themselves are labeled, handwritten up in the upper right. So up here, you'll see on the slide, it will say handout, and then it'll give you like the page label. So in this case, this slide is going to deal with what you'll see on this part of the handout. You can pull it up so you have it right there with you to help you follow along. So this first case is Mr. M. He's a 76-year-old, as we said, peripheral vascular disease in the right BK, and they got an additional documentation request for this person. He was labeled as a K3, right? So in order to be a K3, they had to support that with some information. And the way they supported K3 was they said, oh, he has variable cadence, and he uses the prosthesis for more than simple locomotion. And that's a good start, but then you have to back that up with what exactly he does that requires variable cadence. So I put things in red that were missing from the practitioner's notes in this case. So they said variable cadence, but they didn't say what for. And basically in this case, we're just going to ask, well, okay, the person's varying their cadence. Why? They're chasing after kids. They're catching the bus. What are they doing that would cause them to need variable cadence? As far as prosthetic use beyond simple locomotion, that was addressed in the notes, as they described that the person needed to golf several times a week, and that would cause them to be on uneven ground, etc., and use different body mechanics than just walking or ADLs. So that makes perfect sense. And I've heard talk out there that says, well, we don't want to put hobbies and that kind of stuff, but you do, because golf or something like that is a way for them to get involved in the community and maintain their health and that kind of thing. So that's a legitimate thing to put as an activity that the prosthesis will help with. When we talk about this case too, we talk about what this person's going to do with the prosthesis. So that we wanted to kind of give some background, again, to support that the person is a K3, and also just to support that he needs a prosthesis and he's going to use it. And so we're going to talk about community involvement. That's another thing that Medicare wants to see for patients. And so what was missing in the notes from this particular practitioner was, what was the community involvement? They want to know, Medicare needs to know that the person isn't going to get this expensive prosthesis and then go home and sit in front of the TV all day, that they're actually going to use it. Or if they do sit in front of the TV all day, that they're labeled at a level that makes sense for that. So you get that. We need to talk about the functional activities that this person is doing that requires them to use a prosthesis. So really outline those in some great detail when you're talking about that, and use the term functional activity, because that's one of those happy buzzwords that we like to use. So link it to function, link everything that you're doing for that patient to their day-to-day function. Okay, so on this case one, right, the practitioner had put justifications for every code, and they were long justifications with a lot of detail, so that could be good or bad. In this case, this was a lot of detail, but it wasn't necessarily detail that was helpful. So let's look at the actual justification from this practitioner for the foot that this Mr. M got. The practitioner writes that the foot is an energy storing dynamic response foot, that allows for a smooth heel-toe transition, increased stance phase duration, improved symmetry, etc. And it has multi-axial rotation that permits improved ground compliance, blah, blah, blah. Ankle movement that absorbs ground reaction forces while walking, and that this foot allows 8 degrees of coronal plane movement. So that was the justification for this patient for this foot. I'm sure that some of you would say, oh, this looks really good. Actually, 5 years ago, I would have said, wow, that's a heck of a justification. That's really good. I wish mine looked that good. Now, hopefully, we're all looking at that and going, well, it's good, but it seems a little generic, right? It doesn't seem like it's really linked to the patient. But I would challenge you to go one step further from that. Firstly, it's too generic. Secondly, it's not linked to the patient, and we need to do that. So we're going to give an example of how to do that. And then thirdly, look at all the jargon. So again, I'm going to say that reviewer at Medicare is not, a high school dropout that can't read. It's someone who has a medical background, usually, or who at least has some level of education and can read. It's not the problem that they're not educated. The problem is that if you look at the jargon in this, it's a little overwhelming. To us, this makes perfect sense. We see it every day, so we forget that to a layperson or someone who doesn't deal with prosthetics all the time, this could be very confusing. I did a little experiment, and I gave this justification, just as you see it here on the screen, to my mom, and had her read it. And I said, can you tell me what this foot does? And she was so lost and so confused and said, I don't know what any of these things mean. I don't get it at all. My mom's educated. It's just that she doesn't have experience with prosthetics. So we need to really watch out on jargon and really start wording things in a way that anyone can understand. So let's talk about how we can improve this, okay? And just taking one part of one particular feature of this foot and kind of drawing it out here to expand upon it. Let's say that firstly, we're going to use the patient's name frequently so that it's clear we're still talking about this one patient. We're not using template wording. So we're going to say Mr. M requires dynamic response to have even stride and improved symmetry. Okay, that's where the last note kind of stopped. Now we're going to add what that means for the patient and what that means functionally. So improve symmetry, because that will reduce fatigue and increase endurance. Well, don't we want that for everybody? Why would this guy need that where, the last lady didn't need that? Well, he needs this particularly because he wants to return to golf, and that's going to help with his quality of life. quality of life is a legit way to justify something for a patient. You need to look at the overall picture of the patient. And if getting them out on the golf course is going to keep them from staying in the house and getting depressed, that's legit. So you can use that. Yeah, as long as it's well explained. And then we're going to take it even further. We also need to reduce fatigue and increase endurance because this patient has a history of hypertension and myocardial infarction. And that's in the doctor's notes. So now not only are we better explaining the need for this design feature, and when I say design feature, see dollar signs, right? Because every time we're talking about justifying a design feature or a particular thing about this foot, we're usually talking about a separate L code. And if you're going to add L codes and add hundreds or maybe thousands of dollars to the claim, you need to support that to say, we need that extra funding and we need you to spend that extra money, Medicare, because he's going to get something big out of that. So we're increasing quality of life and we're linking it to his medical picture. And here again, we're going to link this directly to those doctor's notes and use the doctor's notes as part of our justification for this foot. So because he has that history, the reviewer might say, oh, well, if he has a history of hypertension and myocardial infarction, he shouldn't be walking at all. Maybe we just don't need a prosthesis. So now you've linked it to his healthcare, but then you're going to take it a little further and say, look, yes, he's had heart problems, but his doctor in his notes has stated that those are under control with medication. We just want to make sure that whatever prosthesis we create for this person doesn't exacerbate anything. And that's why we need to give it these features to reduce the fatigue. Okay. And let's even go, let's explain that even further or give it even more detail. And before I do that, let me point out that we didn't add a ton of words here, right? We went from maybe one line or the original justification. Where's that? This is a lot of wording, right? That's a lot of writing potentially. So we're maybe adding the same amount of words or the same amount of writing here with this justification, but it's more specific. I just want to highlight that I'm not saying that you should write a book about every single design feature of every single item that you bill. I'm just saying make it more specific and less generic. And often that leads to the same amount of writing or even a little less. Okay, so that was a side note. I'm back on track. Here I go. What else does Mr. M need that even stride length for? Why is that so important? And that improves step symmetry that this particular expensive foot has. Well, he needs it also because it will decrease overuse of his non-amputated side. Why is that a big deal? Because we need to protect his skin. Why would his skin be at risk? Well, guess what? He had recent history of ulcers on the left foot. Well, how do you know that? Where did you get that information? From the patient? No, we got it from the doctor's notes. It was in the doctor's notes that he had a recent history of ulcers. And you could add that here that, the doctor or the nurse or the wound care clinic people had addressed this ulcer, they healed it, but we still have to be careful. So we're creating a prosthesis that takes into account all of his comorbidities and really protects him so that he can get out there and live some life and not further damage his extremities, right? Okay, so let's also look at one of my favorite features, right? Multi-axial movement. Firstly, multi-axial movement means nothing to anybody except us and P&O. Nobody gets that. Okay, so we want to just, again, put it in just plain language, not stupid language, not dumbed down language, just plain language. So Mr. M requires multi-axial movement, and that is movement up, down, and side to side of the ankle, right? And he needs rotation capability of the foot and ankle. He needs it to twist, right? Why does he need that? Well, we have to absorb the forces of walking. Well, why does he need to absorb forces of walking? Because we want to prevent those forces from coming up to the knee. Now, I would hazard to guess that most people, their notes at least have, or a lot of practitioners now, that you're changing the way we're documenting, have at least this level of information. But I'm saying let's take it to that next level and really, again, link it to his medical conditions and to his doctor's notes. So we need to prevent the forces from transferring up to the knee because for Mr. M, it's really important because Dr. D, Mr. M's doctor, has noted on this date, and you would have the attached notes, that Mr. M had knee surgery in the past for degenerative changes. His knees are at risk. He's had issues with knee pain before and degenerative arthritis, I assume, degenerative changes, whatever, in the past. So we're saying, look, here in the doctor's notes is a case that, or a point saying that this person's knees are at risk. Therefore, here's why we need this feature of the prosthesis, because we want to get him out in the community, we want to get him working, but we also want to protect his knees. And that's important. Okay, so here's a question, I think. Case 1A, when referring to the doctor note stating Mr. M will be able to utilize the prosthesis because his heart dysfunction is under control with medication. I have never seen a doctor write something like this because they don't know to put that in their notes or say that. So how do we educate doctors to get doctor's notes to improve and help us? That is a great clarification. I appreciate that question. Let me rephrase, right? Because I think you bring up a super good point, and that's that the doctor in this case, I'm going to back up here. The doctor in this case didn't write anything about the prosthesis, right? Didn't write anything about how the prosthesis was linked to heart function or how the medications were linked. This is our wording, right? This is my wording and the practitioner's wording on this case. So we said, okay, we're going to give this guy a leg, but he's got hypertension and myocardial infarction history, right? And that's in the notes. So we want to make sure that we also pull something from the doctor's notes saying that that won't be an issue. So the only thing that was in the doctor's note, in this case, this was the cardiac doctor, is that his heart condition is well controlled with medication. That was it. It didn't say anything about a prosthesis. He didn't use the word prosthesis anywhere in this 3-page note that he wrote, this particular doctor. What we did is we said, here's what the prosthesis does. Here is the medical history that we see from the chart notes from the doctor. And let me show you, reviewer, that it's okay for him to walk because according to this doctor, his heart condition is under control with meds, right? So we made that link. The doctor didn't make that link. In a perfect world, and in a world where every doctor follows the rules of the Dear Physician letter, which that is definitely a perfect world that I haven't seen. But let's say that we're in that place right now where every doctor follows everything from the Dear Physician letter. If that were the case, the doctor would have written, this person can wear a prosthesis because his heart condition is under control and I want him to exercise. That would be beautiful. They don't do that. That world doesn't exist right now. I'm saying continue to educate your doctors and tell them what you need. And when you write up these notes like this, even send it to them afterwards and say, hey, this is what we did. This is how we discussed it. Maybe you want to take a look. Maybe they read it, maybe they don't. But at least you're keeping them informed or trying to. So you're going to keep trying to educate those doctors. But today, when your doctor has no idea what to do and you can't get an appointment with him and you still have to bill, right, and see patients, for today, you're going to make the link instead of him making the link. I want to be clear that it is not an ideal setup. If we're following Medicare guidelines to the letter, then the doctor would need to make this link. But since that's not possible for us right now for most practices, and we're trying to get there, but we're not there yet, we have to make the link in the interim. I want to take a little side note here to say that in that case, for case number 1 we just looked at, this was a picture that I received in that file with that case. Oh, wait, here's a further question here. Okay, well, how do doctors determine the patient's K level? Because that has to be included in their medical notes. Thank you for that. And you're right. And actually, case number 3 that we're going to talk about addresses that exact point. So let me go to case number 3 here toward the end. And if I still haven't answered that, please, type in another question and say, no, not good enough. Okay. But yeah, I think I see where you're going, and we're going to look at it in case number 3. So the side note of pictures, there's been a lot of debate, I think, on pictures and video and whether you should include them or not on your claims. In this case, I get this a lot. I get files from people, and it's the same file that they're going to be sending to Medicare, and these are the kind of pictures I get. What good is this picture? It is no good at all. It doesn't mean anything. You wasted paper and time by putting a picture like this in there. Even if this picture was awesome and amazing and showed some kind of scarring or weird shape or whatever it was intended to show, it wasn't addressed in the notes. It's some random picture stabbed in there without anything that says refer to picture blah, blah, blah to show the scarring here, which makes me want to use whatever liner, you know what I mean? So I would say you can use notes and videos, and technically they they could look at it, and it might help you further down. Say you got to ALJ level, then it might be really helpful. So you could definitely turn the videos and pictures in. However, you just want to make sure that that you can see them, and you want to make sure that you've explained them in the notes in words. So all of that is to say, if you're using pictures to take the place of words, that won't work. You have to have both, right? So you also have to describe it. And again, because the whole system is based on verbiage, not pictures. Okay, here's a question or comment. You refer to reviewers as being educated, but then you say they don't know what multi-axial means. I find it hard to write a note that does not sound condescending, good point, but gets my point across. Either they should be better educated in our area, or I need to be educated on how to educate them, right? I think that's a really good point. It's really hard to make notes that don't use a lot of jargon, but also skirt that fine line where they don't sound like you're writing it for a 2-year-old, right? So you want to be careful, like you said, not to use condescending language. But as you see in this slide, I just throw in anytime you have a word like multi-axial movement, that maybe isn't clear to everybody outside of P&O, just throw in a quick description of what that is. So I don't feel like this is condescending. Maybe it is to some people, but you have to do something, right? But you're right. It's hard to write a note that is not condescending. And that's why I say all of this writing stuff is going to take a little practice and some work to get it. But just a little something like that. Multi-axial movement, which means movement up, down, side to side. And I should put at the ankle right there. I think, is enough to make it a little clearer. And I'm not saying that you have time to take all of your notes over to a family member who doesn't work in P&O and have them read it and see if they can understand it. But maybe you do a spot check here and there. That's what I've done quite a bit, and I found it incredibly helpful, where I'll take something that I've written, and just to check if I've got too much jargon, I'll take it to someone outside of P&O that I know who is educated, who is, a good who's a professional in some other field, and say, does this make sense to you? Could you just read this one paragraph and tell me if you can understand what I'm saying? And I did that maybe, once every other month, and maybe you only do that on the really complicated, expensive cases that you anticipate having a lot of static about or a lot of issues with. But it can be a good spot check. But I take your point. Yes, very true that it's hard to write something that isn't condescending, but still explains what you're trying to explain. And it just takes a little practice to do it, but it can be rocky in the beginning, that's for sure. So, okay, so let's talk about case 2. I am so pumped about case 2 because I think it totally illustrates this point about getting doctor's notes ahead of time. And I get a lot of pushback on that when I tell people, hey, maybe especially on this microprocessor knee, maybe you could go ahead and get doctor's notes ahead of time, just because you're probably going to get pushback on your billing. It's probably not just going to sail through with no issues. Or like right now, there's a lot of auditing going on with AFOs, L1960s, especially in a lot of areas. So with that in mind, maybe on those cases for the foreseeable, for the next few months, you would get the doctor's notes ahead of time. You can ease into this. You don't have to say company policy, we get doctor's notes before we do anything on every single patient and make everybody insane. You don't have to do that, but I'm saying like maybe you pick and choose. On this one, I think is a great illustration of how this would have gone so much better had they gotten the doctor's notes. So this is this Mrs. P, 66-year-old, right? Doesn't seem too complicated here, but it was denied because of lack of doctor's notes. And again, like I said in the beginning, there were plenty of doctor's notes. No lack of doctor's notes. It was just that the doctor's notes didn't seem relevant or weren't linked up. In this case, again, it's extreme. The doctor's notes actually completely contradicted what the prosthetist was saying, which is a problem, right? So this is where I make the argument for a timeline of care. If you write up a timeline of care on the patient, then it can really make things so much clearer for you, for the reviewer, for everybody involved. And a timeline of care is this: you get a stack of doctor's notes, some from the wound care clinic, some from their primary care physician, and you've got your notes there as well. And you sit down with those and you take the dates and you just put, okay, here's a chart note for this date. What was the general idea of what happened at that date on that at that visit? And you do that for every visit you have there, which in my experience so far over the past year and a half, even with a big stack of doctor's notes, I end up with maybe a 1 or 2 page timeline. It's not terribly long. Again, please understand, I know this is extra work for you. I'm not saying any of this flippantly, and I'm not saying that this is going to be a breeze for you, or that, oh, just write up a timeline of care because you've got so much time on your hands, you don't have anything else to do. I totally get that this is another burden. But in the end, what it would hopefully do, and what experience has shown us it does, is eliminate the burden of dealing with a lot of audits and appeals. So we're swapping the burden here. We want to nip it in the bud in the beginning so that we don't have to deal with it as much later. And this has been working so far. Again, that's experience based, but this has been working for a lot of practices that I work with, where we spend the time to make the timeline of care. We find information we wouldn't have seen before, and it has really decreased the burden on the back end of dealing with audits on this. So, okay, back to the point. Let's look at the timeline of care for Miss P here. Anything in blue is going to be the prosthetist notes, and anything in black, in this case, would be the doctor's notes, okay? So we just made this timeline. We said, okay, on the 8th of April, the patient was in to see the prosthetist, the test socket fit well, and the patient stated that she's going to go to physical therapy. Then the same day, she also saw her regular doctor, who charted that there was a wound in the groin and pain with the prosthesis when she wore the prosthesis. Okay, there was nothing about that in the prosthetist notes, which is odd, right? For whatever reason, maybe she didn't mention it to him. Who knows? And then she goes back to the prosthetist on the 23rd, and everything goes well. They do a check socket fitting, whatever. And she says, oh, yeah, I'm still trying to work on getting physical therapy set up, because the prosthetist said, hey, have you gotten physical therapy? You're going to, get it set up because you're going to need it soon. Oh, yeah, I'm working on it, she says, right? Then on 6/6, she goes into the doctor, and the doctor writes a bunch of notes, this is what's going on, and ends with the patient generally is just not caring for herself because she's not doing what she needs to do. Then she goes back to that doctor in August, and the doctor charts that a power mobility device, PMD, is needed because she has shoulder pain. It's progressively gotten worse. She can't do her ADLs. She is weak, and she should avoid activity. Wow, really? Because here she is getting a prosthesis, or a new socket for her prosthesis, right? She goes back just a few days later, 8/13/8/21, to see the prosthetist, and his note says patient uses leg 10 plus hours a day. Yes, I adjusted the socket because there was some groin pain. That's quite a gap right there. Groin pain here, groin pain there. But whatever. Adjusted the socket to address the groin pain. Everything's great. What? So imagine if you're a reviewer and you create, let me back up here too and say that in Medicare guidelines for how reviewers do their job, it says that the first thing they do is pull all the file information on the patient and create a timeline of care. That's their first step. Okay, so if you do that step, you can see what they're seeing, and you can understand how they come to these conclusions, right? If I knew this, if I had seen this timeline of care, even as a practitioner, I would say, wow, okay, there's a problem. I could see how this leg might get denied, right? Because based on this, she doesn't need a prosthesis at all. So why are we even doing a socket change on this? Okay. And she's definitely not a high-end user. If she does need a prosthesis, it's going to be a very low-level prosthesis, maybe, based on this timeline. Let's go even further and look at the rest of the timeline. Here she goes back to the prosthetist on the 22nd of October, and the prosthetist says, okay, wearing the prosthesis every day. This patient's a K3 level ambulator. Really? Socket doesn't fit, but patient's gait is good. Okay. But, even though her socket doesn't fit, she's still moving. New socket will allow increased activity to control weight. So there are a few problems here. Firstly, if we knew, so that at the time that the prosthetist wrote this note, he did not have the doctor's notes that we were looking at here, right? He got those much later. The office staff for him got the notes, popped them in the chart, which is common for most practices, and he never saw them, right? So he wasn't aware of what this patient was telling her doctor versus what she was telling him. And clearly she was telling them two different things, right? So, and how would he know that? If she comes into his office and she tells him, I wear it every day for 10 hours, she gets up in the parallel bars and starts walking and showing him that she can walk well, even though the socket needs adjustment. maybe he would come up. Why wouldn't you come up with a K3 level diagnosis, right? And she's saying, oh yeah, I live by myself. I'm doing all these things at home. I'm making meals. I'm going to the bus. She's telling him all this. Of course he's going to put her at a K3. Why wouldn't he? Right. But then if he had known what the doctor was charting this whole time, he could have avoided a lot of headache going forward. And we'll talk about how we fixed it or came around here. But the other thing that's wrong with this, or bad about this documentation, is the justification for the new socket. It will allow increased activity to control weight. Well, her BMI, according to her doctor's notes, is 23. She's well within the range of normal. She doesn't need to control her weight. I mean, we all need to control our weight, right? But weight isn't an issue for her. If you knew from the doctor's notes that her BMI was this low, you wouldn't choose that particular justification for a new socket. Right? So there's another place where it was off base from what the doctor was saying. Now, just a little bit later, right? Maybe a week later here, a couple weeks later, she goes back to the doctor after this visit with the prosthetist saying, oh yeah, everything's great. We did a new socket, sent it out. We're going to bill for it. She goes back to the doctor. Power mobility device definitely needed. She has COPD, congestive heart failure, and amputation, all of which causes difficulty with ambulation. She doesn't have good endurance. She can't do her ADLs. Her QOL, or her quality of life, is low. The patient has had multiple accidents. What? Multiple accidents? You'd think she would have mentioned that to the prosthetist, right? So what is going on here? She can't use a walker. She can't use a cane or a manual chair. I mean, this woman, according to the doctor, is, a lump of jello compared to what the prosthetist sees is this woman who's trying to walk in the parallel bars and do her thing and get back to her life, right? Motivated and willing to use a power mobility device. That's how we end that note. So again, the timeline of care and having the notes ahead of time or during really illustrates that we're getting two different pictures on this patient. And you could see where the reviewer would deny that socket, right? It makes a little more sense now that you see that the physician is writing all this stuff, right? So here's someone that's a question or a comment. We often struggle, despite a lot of effort and education, to get the necessary notes for pre-op or initial eval from physicians. Yes, that's super hard, especially now that many times it is the primary care physician and they seem reluctant to even address prosthetic issues. How have you managed to get these notes, and such detailed ones at that, after every visit with the doctor? Right. It totally varies. I think that's a great point. It's super hard to get notes like this. It's super hard to get any notes, and especially in a timely manner. Like you say, if I'm saying get notes ahead of time or during care, it may be weeks before the dictation from that doctor gets in and gets processed so that you can get it. So you can get the ones you can get, obviously, and keep working on that. But definitely if there are some that are available and you can get them, you want to start using them. But you're right, you're always going to have these issues with it being very difficult to get the notes. The other part of that was, how do you get detail? I'm not going to leave case 2 completely right now, but again, this case 3, the last case that we're going to look at, is exactly what you're getting to. None of these doctors wrote anything about the prosthesis specifically. In this case, for case 2, they wrote that the prosthesis was causing problems, but they didn't write anything about the patient using it or not using it, whether she had even discussed it with that doctor or not. And in case 3, we have nothing but doom and gloom. Okay, the doctor writes everything that's wrong and doesn't address the prosthesis at all. So what we're going to look at in that case is, how can we take all those negatives and turn that into positive support and justifications for a prosthesis? So I think that's going to address exactly what you're asking there. Let me finish up here with case 2, though, in that we end up with a patient that looks like she kind of played each side. Who knows if that's true? She might not have been doing that on purpose. It might just be what was going on that day. But the bottom line is, you're getting two different stories depending on where you're at. Different doctor's notes may have helped here. So if you got all these primary care physician notes about the patient going to use a power mobility device, maybe you could also get notes from her cardiologist or her orthopedic doctor or something like that that would have a different picture and would give you a better idea of where she really is. And of course, therapy notes would help, but she wouldn't go to therapy. So that definitely makes it tough. So in this particular case, we ended up in a very rough situation. The way this ended, and this ended a week and a half ago, so this is very, very fresh, but the way it ended is, we're going to put in an appeal. Okay, so we're going to put in an appeal to say that this patient, now that we have the information from the doctor's notes that we didn't have before, and I will say they had trouble getting the doctor's notes in this case. There was a lag there. So even if they had tried during care, it might not have been uh, received on time. So in this particular case, they're going to do an appeal where they look at describing that now that we have the information we need from the doctor and we see the different uh, the different sides of the story, we're going to reevaluate the patient, see what the needs are, discuss with the doctor what those needs are, and see about possibly, and this is really confusing, but possibly pulling back that billing, going through with a lesser billing, in this case, maybe a K2 billing, and getting the doctor, the prosthetist, and the patient on the same page, because it appeared that the patient didn't end up getting the power mobility device, and it was unclear why she didn't. So now we can go back and say, okay, well, she didn't get the power mobility device, so she does need a prosthesis, but let's reevaluate why she needs it, and maybe use a questionnaire for her, like the prosthetic evaluation questionnaire, the PEQ, to get some more information from her and to have something a little more quantifiable to put with the claim. So we're kind of right in the middle of this, and it's not totally resolved. And it is a strange kind of extreme case. So we're still working on like how are we going to sort of salvage this from where it's at. But yeah, in the end, the question was who's going to pay Medicare back, right? The doctor or the prosthetist? It's always us. We are always the ones that are going to be at the bottom of that food chain if we're up against the doctor. So of course the doctor is not going to have any consequence for any of that, but this claim is going to be really difficult. So and it says, this other person says, it sounds like if this prosthetist created a timeline of care with given notes and it was timely, he or she would have had to tell the patient and doctor they couldn't have a prosthesis. That seems like a slippery slope as there's an order from the doctor. Correct. That's a good point. And what we ended up with was the person could have a prosthesis. It's not outside the realm of reason. There have been plenty of claims go through where the person had a power mobility device and also a prosthesis. The real thing is that a K3 level prosthesis with more of the higher end technology that they were looking at might not be realistic with a power mobility device. And it was a different doctor that wrote the script for the prosthesis than wrote those notes about the power mobility device. So that made it a little tougher as well. And we didn't get the notes from the doctor who wrote the prescription, is my understanding of it. So complicated. Okay. Also, the woman was switching back and forth, right? One day good, one day bad. So, okay. So those are great questions. Thank you so much for those. That definitely helps clarify all these points. This is tricky stuff. It's really tricky stuff. Okay, so let's talk about case 3 because I think it's going to address a lot of those questions that people had. And I know the time is short. Woo, the time is very short. So I'm going to kind of haul butt through this one. But to make sure we end on time. But this one was an interesting case because the doctor's notes, again, said nothing about the prosthesis or very, very little about the prosthesis, but talked a lot about all the problems this person had, right? So let's look at this on paper, what looks like a train wreck. Okay, the patient is obese and has had 9 falls since the amputation. And I started to think, well, why would he fall so much? He's kind of youngish, I know he's obese, but and he has CMT, that's a problem. Obviously, that could cause you to fall and trip and whatever and have difficulty walking. But why 9 falls? Well, he also had uncontrolled diabetes. There's a problem for balance and what have you, right? Also a drug user. He claims that he's only using marijuana currently, but of course, it doesn't take 1,000 drugs to make you a little bit loopy and make it difficult to stay upright, right? So, and then as if to just pile up on this one, he has congestive or coronary artery disease, high blood pressure, history of cardiac arrest, and again, Charcot-Marie tooth on the sound side. Total disaster. If I'm a reviewer and I look at this, I'd be thinking, well, no way this guy could use a prosthesis. We got to get him a wheelchair. He's falling over all the time. His diabetes is uncontrolled. How could we ever let him use a prosthesis, right? So what we want to look at as far as from Medicare's perspective is that the doctor should be writing the severity of the patient's condition and then saying, but we're going to use a prosthesis for therapeutic benefit on top of that. That's what the doctor should write. And that's what, again, what we're shooting for. Again, often the doctor doesn't write that. So we have to sort of link it up for them. That's a temporary measure. Let me be clear. That's just what we have to do for now if we're going to keep billing. But it's not ideal. We still have to educate our doctors about that. So we had lots of doctor's notes all about falls and terrible things, nothing from the physical therapist or the MD about prosthetic need or overall physical ability. And then the practitioner in this case said, but they signed off on the detailed written order that said the patient was at this level and expected to use it for this length of time and blah, blah, blah. And that's just not enough. It has to be in the notes, right? Another thing that you'll find in the program integrity manual is that the manner in which the equipment or device will restore or improve function should be explained by the treating physician. Okay, once again, your doctor's probably not going to write that right now. We have to keep trying to educate them, but in the meantime, you're not going to get that. And in this case, we didn't get it. They didn't write anything about that, right? So if you can get so far, here's a starting place for educating your doctor. If you can just get the doctors to say something along the lines of, this patient will benefit from the use of a prosthesis, right? Just that much. If we could just say, yes, we want the prosthesis. And back in the day, we would say, well, signing a prescription, asking for a prosthesis is kind of an indication that the doctor feels they would benefit from the prosthesis. That's not the case anymore. So we just want the doctor to put somewhere in the notes, if possible, that the patient would benefit from the prosthesis. From there, we can use the rest of the doctor's note having nothing to do with the prosthesis to help explain why we need that prosthesis for the person. So we're going to extrapolate from there, right? So in this case, the doctor, again, didn't write anything specific, but we do have notes from the RN that works with the doctor that this guy had been advised to get regular exercise and lose weight. So yes, he's got all these heart problems, but his doctor has told him to get regular exercise. Therefore, he's healthy enough to do that, right? And then we would say in our notes to link this up, by using a prosthesis, Mr. H can decrease or eliminate the use of a wheelchair, increase his activity, decrease his BMI, as recommended by the doctor. Okay, so we are making that link that the doctor should make but didn't. And it's kind of the best we can do, right? And someone says, what does PIM stand for? Program Integrity Manual. Sorry, I should spell that out. So a little room on these slides, but yeah, Program Integrity Manual from Medicare. Okay, so this is kind of the key point, right? If the doctor doesn't write anything specific to the prosthesis, you're going to use what you have. In this case, it was awesome that the doctor they wanted the guy to exercise. That was something we could really grab onto and use for justifications. So let's link that up, right? Yes, this patient has a history of coronary artery disease, high blood pressure, cardiac arrest, etc. So in designing a prosthesis, it's really important that we limit his exertion, but still allow him to be active. How do we do that? We do that by making a lightweight prosthesis and making sure that the foot has a flexible keel. This will allow him to have more even stride lengths and exert less as when he's rolling over the toe, right? That will lead to decreased fatigue, increase his endurance, and then we can protect the non-amputated side. So the features of the prosthesis and of the foot in this case are woven in here with his current comorbid conditions. So we're not ignoring that he has comorbid conditions. We're not ignoring that the doctor's note was 9 pages of the sky is falling and the sky is coming apart. We're saying we recognize this guy has health issues, but the prosthesis can be part of the cure, can be part of the solution for making him healthier, right? And this is how we would do that. So we're describing his daily functional activities. We're saying, look, he's going to get out and do this. He's going to get out and be active. And that's going to improve quality of life and what have you. He's going to discharge home. That was in the notes. He will attend therapy with the prosthesis. That was part of the plan that they had going forward in the notes. And then where we need to add more detail, especially in this case, is what is he going to do? What is that daily functional activity? Does he care for kids? How often does he do that? Can he help with household chores? Again, we're going to use the prosthesis on a daily basis, and it's going to help him get back to his former life, which was blah, blah, blah. And we just need to add that, right? Okay. So we made it through. I apologize. I think I'm right at time and we didn't leave time for questions. Okay, here's my contact information. That was a lot of information. I recognize that in a short time. So certainly, if you wanted to ask more questions, or if we didn't get to your question during this, and you needed to get that out, please let me know. And of course, thank you so much to SPS who sponsors these monthly webinars and makes it possible again for you to get the credits with this free, and also is a facilitator to help me work with people and get these cases out to you guys so we can all learn from them. So here again is my contact information. And I will hang on here for just a couple more seconds because I know that was rushed at the end. And if you had questions, I want to make sure we get to it. One question, what was the form you mentioned that Mrs. P should fill out? A PEQ or something like that? Yeah, it is a PEQ. The prosthesis evaluation questionnaire, PEQ, you can look it up on online. You can Google it and it will come up. And it's free, I do believe. It's a long questionnaire, but you can cut it up into sections if you want. And it's validated and it's been around for quite a while. And it's a good way to get a better read on what the patient is expecting of the prosthesis and what they want to do with it. So something to keep in mind. But yeah, you can use that. Okay, thanks so much for your questions and for being interactive and making this a more interesting session. And again, if you have questions, contact me. And thanks again to SPS for the sponsorship of it. Appreciate your time.